Hello and welcome. Thanks to all of you for joining today's update on innovation with Dr. Stephen Schuster with UCHealth. I'm Erica Seamers, Regional Executive Director for the UCHealth Northern Colorado Foundation. Our foundation supports Poudre Valley Hospital, Medical Center of the Rockies, Greeley Hospital, and the UCHealth Cancer Center on Harmony campus through donations made by generous community members. Donor contributions help to fill in gaps not covered by insurance, to accelerate advances in medicine, all ensuring that we can bring the very best healthcare to our region. Community support, like much of that those of you on the call today have provided for us, helps us to care comprehensively for the health of our community. As a few examples, donor contributions helped to build the UCHealth Cancer Center, where we're broadcasting from today, which opened its doors in 2014. Philanthropy continues to support cancer research and treatment, as well as to provide financial assistance for cancer patients in need. Our mobile blood buses, provided through donor generosity, also have been instrumental in gathering vital blood platelets, and plasma during the pandemic. Donor contributions to medical research through the foundation are currently being used in numerous ways, in particular to help COVID-19 patients, enabling our doctors to better understand related blood clotting issues and to guide patient care. We're so pleased to be with you today and to bring today's presentation to you from the UCHealth Cancer Center. In fact, right now we're in the Carroll Family Conference Room right here on Harmony campus. And we are practicing today's meeting in a physically distanced manner. So we are safely coming to you today. With that, it is now my great pleasure to introduce today's speaker, Dr. Stephen Schuster. He is Medical Director of Oncology Clinical Research for UCHealth in Northern Colorado. His specialty is blood cancers, lymphatic disorders, and blood disorders. He's a graduate of University of Missouri School of Medicine and completed his residency and fellowship at the Mayo Clinic. I'll hand it over now to Dr. Schuster.
Thank you so much, Erica. Good afternoon, everyone. Thanks for taking some time out of your day to come listen to me talk about innovation both in oncology and in COVID-19. So hopefully I can do this and we can get started. So moving forward, so kind of an overview of what we want to talk about today are four things. First, I want to talk about updates with immunotherapy and cancer care and really focus on what our research team does. And then give a summary of our UCHealth team and the research team, which is very generously supported by the community, which is an exceptional and unique finding in Northern Colorado. And third, what I know a lot of people want to talk about is its key points about COVID-19 and the research that we're doing here at UCHealth in the Northern region in collaboration with CSU for some of those studies. And then finally, leaving some time open for questions. I believe you can submit questions via this program as we go. We'll answer those towards the end, but if you have a question as we go, feel free to type them in, and everyone's going to be getting those for us at the end. So, getting started with immunotherapy in oncology. Okay. So I'm going to give some examples about how cancer care in 2020 is quite different than it was even just 10 years ago, and look at a variety of different examples to illustrate that. So looking at a type of lung cancer, the most common type, non-small cell lung cancer. We had a study that came out in 2016. It was a phase 3 study in metastatic lung cancer looking at an immunotherapy called pembrolizumab versus standard chemotherapy. And the hope with this study is that we would see that these would be at least similar, was the goal with that. Well, we actually found, comparing immunotherapy versus chemotherapy, that patients actually did better with the immunotherapy. The amount of time until their next treatment, what we call progression-free survival, went from 6 months up to 10.3 months. And then the overall survival, which of course is the most important thing, when we looked at the 6-month time point, we had a clinically significant improvement in that. And so that led to future studies where we said, okay, now we know immune therapy is a key part for lung cancer management. What can we do to make that better? And so one of the ways we did that is actually combining it with chemotherapy. It's nice that it works by itself, but what we really learned with a study like this in 2018, that adding immunotherapy to our chemotherapy dramatically improved outcomes. And this slide, I still remember one of my lung cancer mentors talking about how important it was to make improvements in lung cancer. And we were hoping with a lot of our different trials to get maybe a 3 or 5% improvement with each new remedy that came through. And this one, as you can see on the right over here, when we're looking at overall survival, we had a 51% reduced risk of death at the 1-year time point when we added immunotherapy to our standard chemotherapy. And this was in metastatic patients. And so seeing that curve, what we call a Kaplan-Meier curve, seeing that great gap, that lightly shaded green area that you can see, having that be so large is dramatic. And when you actually look at just the United States, that's the equivalent of saving about 50,000 lives per year from metastatic lung cancer, just right there. And we've learned more with this since 2018, looking at different regimens that we use, et cetera. But this really has revolutionized how we treat cancer. So ASCO, the American Society of Clinical Oncology, really determined in 2018 that that was the big breakthrough of the decade, really, is the use of immunotherapy in combination with chemotherapy. And so I want to talk about, well, what is immunotherapy? How does it work? And so in order to understand that, we need to back up and look at what's supposed to happen in the body. And so if someone were to develop a cancer cell, and so we have these really ugly looking red cells on the left, those are tumor cells. What's supposed to happen is that the immune system identifies those, recognizes that there's a cancer, and gets rid of it. And then those ugly cells die on the right side. And so we believe that many people will have a cancer for a short period of time, but their immune system identifies it, gets rid of it, and they have no idea that they've ever had cancer. That's how things are supposed to work. Unfortunately, if people have to come to the cancer center, that means it didn't work. And we needed to understand why it didn't work, and then how could we reverse that and make it work again. And so one of the ways to understand that is to look at the T cell. So this is an immune cell that really in a lot of ways is the general of the immune system. It's in charge of the immune response. And it has activating pathways and inhibiting pathways, which you can see on the left and the right. And I liken those to like light switches. You know, if we stimulate the things on the left, it turns the T cell on. If we stimulate the things on the right, it turns the T cell off. And so what cancer's learned to do is to cover itself with things that stimulate a variety of the inhibitory pathways, like PD-1 and CTLA-4, just as examples. And so the T cell tries to come recognize the cancer cell, but because it turns it off, it essentially hits the off switch, and then the T cell floats away and the cancer continues to grow. And so when we look at a lot of our different therapies, we have drugs that target both the antigens that stimulate CTLA-4 and PD-1, ipilimumab, and then there's multiple different PD-1 inhibitors, which we're going to talk about. And by doing that, we're essentially preventing the cancer from turning off the T cell. And then the T cell wakes up and says, oh my goodness, there's cancer everywhere. We need to get the immune system going after it. And so another way of looking at it, I talked about the balance in the body with the immune system, which is so critical. So many medical conditions have to do with the immune system being thrown off balance. You need the ability to activate. If you get an infection, for example, we need the immune system to be able to turn on, but then eventually it has to turn off. So it's natural and very important that we have these activating and inhibitory pathways. I've kind of covered this already, but really looking at what this looks like microscopically, I imagine these proteins are sticking out of the cell almost like hair growing on the cell or grass growing, if you can imagine that. It's not actually hair, these are proteins. And so they're interacting between these different cells. And when the tumor cell has a lot of PD-L1 on it, it's turning off the T cell by stimulating its inhibitory pathways. So what do? You can see these upside down Ys. We have the green Ys and the purple Ys. Those are our drugs. Those are the immunotherapies that we use. And essentially what we do, all they do, they're very simple drugs. They cover up those PD-1 and CTLA-4 stimulators to allow the activating pathways, the things that the immune system is supposed to identify, those things can work again because those were being prevented because the T cell was being turned off. Very, very simple, actually. And so by doing that, all of a sudden, like I said, the immune system says, wait a minute, there's a bunch of bad guys here, we need to go after them. And this is just an illustration just to see a bunch of bad red cells dying and all the different pathways, which the quiz at the end will cover these different pathways. So I made that sound really easy. You know, you'd think, gosh, we've figured out cancer, this is going to be quite straightforward. There are a variety of things that do still make this challenging, and I'll cover a couple of those. One's called pseudo progression, and then, of course, the side effects with therapy. You know, these therapies absolutely are more tolerable in general than chemotherapy, but they don't come without risk, particularly autoimmune problems. So talking about pseudo progression first, what is that? So if you look here on the top, on the left side, you just have your tumor, that's the tumor there. But then when we do a scan, say 2-3 months later, we may see, the radiologist may say, oh, the tumor's growing. But with immunotherapy, you don't know necessarily why it looks larger. It could be, of course, on the bottom, the bad news that the cancer is resistant to our immune therapy and it actually truly is growing. What we hope for, and what we thankfully see more often than not, is that the immune system actually is attacking that, bringing a lot of other cells with it, all those T cells, natural killer cells, immune cells, a lot of fluid with that as well. And so almost like a marshmallow on a fire, the cancer puffs up. And so it's not unusual for us to see some growth of a cancer before it shrinks, and then later on we see it shrinking. So it creates some challenges in determining really, is this therapy working or not. That's what pseudoprogression is. When we look at side effects from immunotherapy, I mentioned a few moments ago that what we're doing essentially is turning on our T cells. We're preventing those inhibitory pathways from being targeted. And so the immune system now can be quite activated. And so any disease that is immune mediated, and some of those are just listed here, they range from colitis in the colon to hepatitis in the liver. We can get rash, thyroid dysfunction is quite common. We essentially have turned on the immune system too much, and now it's attacking some part of the body. That sounds terrible, of course. In that picture, there's things all over the body. You know, one of the nice things, though, unlike chemotherapy, immune therapy, the side effects tend to be early and they tend to get better. So what I'm showing here is 4 of the more common side effects with immune therapies and when they start. Most of them happen a month, maybe 2 months into our therapy, and thankfully, naturally, they go away usually 1 to 2 months later. And so if we can figure out how to manage the side effect, deal with the side effect, it often gets better. There's one thing that the green line, I don't know if you can see the green line or not, how the color is coming through, has to do with a lot of our endocrine or hormone abnormalities. So things like thyroid dysfunction, etc. Some of those things can be later side effects, but often those are easy to manage. That might be a thyroid supplement or something like that. So even though we can get quite a wide range of side effects, many people don't get them, and if they do, they tend to be short-lived, which is the good news. And if someone does get a serious side effect, well, what do we do? Well, the first thing is to stop the immunotherapy, that antibody-based therapy that we're using that's turning on the T cells by blocking the inhibitory pathways. We need to stop that temporarily. And then we need to calm the T cells down. And the way we usually do that is with steroids, for example, prednisone or dexamethasone. And then we need to support whatever the problem is. I've mentioned thyroid, we may need to give some thyroid supplement. If it's the pancreas or the colon, if there's anything we need to do for support there. What's quite remarkable, though, is even if someone gets a side effect, we very frequently can get it under control, as I've shown here, and then resume therapy later and not have that side effect again. I showed that slide earlier, how this becomes easier with time. That's a part of it, but also I think the immune system tends to balance itself out. The immune system does try its best to be in balance. So another point about immunotherapy is, well, great, we've shown the ability to combine it with chemotherapy. Well, what if we use multiple immunotherapies together? And we do that in a lot of different situations. Melanoma is a classic example, which we'll look at in a second. And we do see better response. But one of the negatives, the more and more we block those inhibitory pathways, if we use combination therapy, which you can see in the right column, our side effects really go up. And so a lot of times what we'll do is start with combination therapy, be aggressive that way, and then as soon as we feel we're getting the cancer under control, we often will drop the ipilimumab, for example, and then continue the PD-L1 inhibitor. In this slide, the examples of nivolumab. So I want to give a few examples because a lot of times people have questions about, well, what about my type of cancer or my friend's type of cancer? Some areas of cancer, really immunotherapy has touched all parts of hematology and oncology, some more than others though. And so, breast cancer, of course, being our most common cancer we see here, we have had some benefit here. When we look at a study that was published in November 2018, we looked at adding one of the PD-L1 inhibitors, like nivolumab, I just showed a second one ago, this one's called atezolizumab. And we looked at, well, what if we combine that with a standard chemotherapy? We did see a trend towards improved survival with it. However, we did see more patients have to stop therapy. That discontinuation rate was almost double. And then that trend towards survival, what this tells me is, really, is this the right combination? I think in breast cancer in particular, there's hope, but we need a lot more research to really figure out how will immunotherapy really play the best role. So I mentioned the example of melanoma, so that was an example that wasn't the most exciting. This is one that has really been one of the most revolutionary in cancer care. And so this is a study that the numbers don't matter as much, but when we look at just a few years ago, before we had immunotherapy, this survival curve, so the number of patients that are surviving months down the road, if we looked at the traditional 1 year and 5 year survival for metastatic melanoma, not that long ago, we were looking at 25% at 1 year and 16% at 5 years. And this trial actually looked at 3 different ways of using immunotherapy, either the 2 drugs separately or the combination. And as you can see, that star there is where the traditional survival curve would have been. And for those who don't look at Kaplan-Meier curves all the time, the lower it is, the worse it is. You want that curve to stay as high as it can. And to see something that is really off the charts compared to our standard chemotherapy regimens, really, as I said, Asker said as well, really revolutionized our cancer care. So I spent a lot of time talking about what we call checkpoint inhibitors, those inhibitory pathways to T cells. Those really are key in a lot of our trials that we do here. But there's other key things in immune therapy that are standard that we use all the time as well. So monoclonal antibodies, those are also stimulate the immune system, but they're looking for targets on the cancer. So rituximab is our first example, our classic example. Going for lymphoma is the most common scenario. Looking at something called CD20, it finds CD20, binds it, and tells the immune system, hey, come over here, I found one of the bad guys. Daratumumab, something we use in multiple myeloma, goes after a target called CD38. In hematology, we don't really have interesting names, we just number everything. But these really have dramatically helped, in these 2 examples, our heme malignancy survival rates, success rates, really made a lot of these cases chronic diseases where in the past they could be quite severe. There's another class that's really quite interesting. It's called an antibody drug conjugate, and we have many of these, several of which we have on trial here. But the first one we really had one called brentuximab. This really is almost like a smart bomb. So it has an antibody, in this case goes after CD30, but then it has chemotherapy attached to it. And so instead of giving a patient large doses of a taxane, like paclitaxel, we're essentially giving a drug that the chemotherapy is very similar to paclitaxel, but it's looking for CD30. CD30 positive cells pull that molecule, the brentuximab, in and start chewing it up, releasing the chemotherapy, and so the chemotherapy is killing that cell from the inside. By doing that, we have great success and limiting toxicity. Nothing is side effect free, but we are able to really have more success and reduce side effects with those antibody drug conjugates. We're going to be seeing more and more of those. So This was sounding a lot like a lecture, so I said, all right, why don't we put a case in? Maybe that'll be slightly more interesting. And so we have a case here of Mrs. Eno Tobacco. And so this is a lady that I actually saw years and years ago, but a 56-year-old female with 3 months of cough and 3 years of trouble with balance. What's key is she's a never smoker. If you didn't figure that out by her name, then I don't know what to say. So looking at her scan here, so this is a CT scan. For those who don't look at those, the problem is over here in that red box. That hole there is not supposed to be there. And we biopsied that, of course, and found that this was a lung cancer. And so you may be asking, lung cancer, never smokers, that doesn't make sense. I do want to highlight that this actually is a really important area of oncology. 10% of cases in men and actually 20% of cases in women, lung cancers happen in never smokers. And it's actually quite a high cause of cancer death in the United States. It's actually, I believe, the 6th most common type. And as you can see, the thing that I see the most of in clinic non-Hodgkin's lymphoma actually is less than that. So if you actually look at research and what would benefit our community more than anything, studying lung cancer in never smokers actually beats so many other things that we spend a lot of time focusing on. But thankfully, a lot of research has happened in lung cancer, particularly in the never smoker group, and we've learned so much about targeted therapies. I know immune therapy is the really exciting new thing this decade, but targeted therapies have been revolutionary for the last couple decades and are really a key part of our therapies still. And so in this case, if we were treating this patient in 2020 instead of over a decade ago when I met this patient, the first thing we would do is send for genetic studies looking for mutations in this patient's cancer. And so if we found an EGFR mutation, we have 2 different pills we may use there. If we found an ALK mutation, there's 4 different options we might use there. And really changing how we treat these patients and getting away from chemotherapy and hopefully making it a chronic disease. There's cases of metastatic lung cancer where we would typically think of survival being measured in 3 to 6 months, where we find 1 or more of these mutations in people living more than a decade. So these really can be home runs in a lot of ways. So in these cases, though, with targeted therapies and in most cases with immune therapy, of course we hope to cure cancer. That always remains the goal. But if we can make it a chronic disease where people live a long, normal life, hopefully, and pass away from heart disease or some other issue, if we can have it where they live with their cancer as opposed to dying from it, that's a great success too. And with our newer therapies with less side effects, having a better quality of life as well. And so that's really what's different about oncology care now compared to 20 years ago. And so just like the immunotherapies, they're a key part, but targeted therapies have to be evaluated for and play a critical role too. So even though that wasn't in my agenda, I snuck it in because it's an important thing to remind folks that the targeted therapies are. So that's the first real half of my presentation talking about immunotherapies and targeted therapies. I do want to talk next about our cancer research team here in the North. And I want to pause and really thank everyone that's on this because I'm shocked and really amazed at the community support that we have for our program. We have the Spring Benefit, of course, last year and other times as well. Really, we couldn't do what we do without the support of many of those on the call and the community here in the region. So looking at our cancer center, so we have 15 oncologists. It's amazing to think about this, but 305 staff on our team and see about 4,000 patients a year. We have nurse navigators, 13 financial counselors, because it's so critical to find ways to cover therapy and have those folks work so hard to get therapy affordable for all of our patients. The luxury for me is I don't have to worry about that. I think about what's the best therapy for my patient, whatever their walk of life or background is, and then that team really helps figure out how can we do that. And with that too, we have 8 oncology social workers, which are angels, of course, and really help patients on this journey that they're on. So looking at just our research team, we have about 70 open clinical trials right now. We typically run between 60 and 80 trials at any given time. We have 12 amazing clinical research coordinators that help us do that. 2 regulatory specialists. We've grown to where we have a data specialist and even a business specialist. We had an intern 2 years ago, which when we got the application for an intern, I wasn't really sure what to do with that, but we had a great intern experience, a nurse manager, and then myself, the medical director. And really the buy-in of the team. So the 12 medical oncologists, the 3 radiation oncologists, and so many surgeons, pathologists, radiologists that really help us be able to have the program that we have. Where are we? We're at the Harmony campus at the Dellenbaugh Research Center. And then our mission really is threefold. One, the most important thing is we want to provide local access to the people in Northern Colorado, Southern Wyoming, to the latest and greatest innovative cancer clinical trials. Of course, we want to contribute to finding a cure and bettering the experience. And then the third thing, which is most important to me, is really our clinical trial conduct. The way we run our clinical trials is of the highest standard. And of course, I'm biased in saying this, but I do think we have that reputation of really being one of the best community centers in the country. So one of the things that shows that is in March of 2014, we were recognized as a lead academic participating site by the NCI. And so west of the Mississippi, I didn't include the East Coast here. But there were 9 awards. UCHealth was one of those awards. And really, when you look at the Mountain West and a lot of the Midwest, we really are the nearest center for a lot of clinical trials. And we have patients from all over that map right there that come here for our studies. One of the other things that we're doing, so the Oncology Research Information Exchange Network, or ORION, this is something we've been participating in for almost 2 years now, I believe. I think it was, not quite 2 years. This is a database that patients essentially volunteer to give an extra vial of blood and samples, and then an anonymous review of their chart. So there's no personal data, but their data can be entered. This slide actually is about 6 months out of date, but we have, at this point, I'm almost certain, over 250,000 patients in this database so far. What we hope to do with it is that really try to speed up our development of new therapies. We've had so much development in the last 2 decades, like I mentioned, but if we could make that more efficient and speed that up, that would be ideal. And really focusing on targeted therapies, immunotherapies, biomarkers, blood tests, ways to identify cancer, track cancer, that's really the main focus of this database. It is a potential if we discover things for new treatment options, clinical trials, and we have some examples of that. A lot of it includes genomic analysis. People remember the Human Genome Project from around 1999, 2000. That cost, I think, roughly $1 billion to do. We can do that same analysis from that project for less than $10,000. And so many of these patients actually have their full genome sequenced, particularly if they have rare cancers, to try to learn more about that disease. So really a neat project. Looking at this is a really US-wide group. A lot of the centers, so Moffitt and Tampa were one of the leaders for this that started it. But all these groups across the country we've been working with, and it's really been a privilege to be part of this team. So that was my somewhat shameless plug for how great my research team is. But now I want to get to what a lot of people were wanting to talk about, was COVID-19, and really focusing, if we wanted to talk about COVID-19, we'd be here till late in the evening. So what I want to try to do is focus on some updates pertinent for Northern Colorado and looking at research that we're involved in here. And so if you look at different studies that UCHealth in the northern region are focused on, we actually have 8 studies that we're doing right now. I'm not going to read these, but I'm going to cover a couple in more detail. I unfortunately don't have time to cover all of them. But what's remarkable is the collaboration we have and the number of investigators that are involved. We have the hospitalists like Dr. Unkapper, Dr. Luckison with cardiology, Dr. Dunn with trauma leads many of our studies, in collaborations with Dr. Elizabeth Ryan and Dr. LaVerge at CSU, a really remarkable study, which I will cover briefly. And these are the 5 others for a total of 8. So really, I think it's important to know there's a lot of COVID-19 research that's happening here locally. So I do want to cover really what's happening, and I put the date of October 28th because COVID-19 is ever changing, and if you look at this presentation a month from now, these things could be out of date. So if you look at our experience in 2020, we've had over 2,500 patients hospitalized at different UCHealth sites across the state in 2020. That's not all positive cases, that's hospitalized cases. The average age for those patients is 56. Unfortunately, in Colorado, the mortality rate for those hospitalized patients is roughly 9%. Thankfully, that's dropping. we've seen about a 50%, slightly more than 50% improvement in the mortality rate since March, and we're seeing that across the country. And that's of course encouraging, but I think something to remember is just how awfully high and terribly high those numbers are. If you think about open heart surgery, really the expectation is that the mortality rate with open heart surgery really should be less than 1%, and across the world less than 2%. And so having something, even if the mortality rate is 3-4%, which is so much better than it was in March, that's still just unspeakably high. And words can't really describe how bad that can be. So this is still, of course, a very serious disease. Unfortunately, too, we're seeing a rising number of cases and hospitalizations. So to demonstrate that, we averaged 1 to 3 new hospitalized patients across all UCHealth sites in July and August. So that's not new diagnoses. Those are folks that are sick enough that they need to be hospitalized. Unfortunately, in October, that's risen to 11 to 15 new hospitalized patients per day. And over the month, that trend has been rising. So I hope that trend reverses, but I just want people to know kind of what's going on. So the doom and gloom, of course, some of the bad news with what I just said there. I want to look at some of the things that we've participated in, what we've done, and why that mortality rate is dropping so much. One of the key ways is with something called convalescent plasma. So first, what is that? So this is donated plasma from COVID-19 survivors. So someone gets through COVID-19, whether or not they're hospitalized, they're doing well, they donate plasma. That plasma should have antibodies in it against COVID-19. And then we give that to new hospitalized patients that are struggling with COVID-19. So really we have a hero, someone that beat COVID-19, that's back at home doing well, going to the blood bank, donating plasma so that we can then give it to someone who's struggling. And through a clinical trial early this summer, we had 85 patients on study that received convalescent plasma through an emergency use program with the FDA, and then later with the University of Colorado Consortium, Plasma Consortium. I said consortium twice, excuse me. And what did we learn with that? And so this has not yet been published, but some of the data that we have is that if you had a high titer of antibodies, that was 23% better than having a low titer. And then early identification is key. If the plasma was given in the first 3 days of hospitalization, that reduced the risk of death by 27%. So if we back up and look at patients receiving a high titer unit of convalescent plasma within the first 3 days, that roughly reduced the risk of death by about 40%. Just that intervention alone, and we'll talk about other interventions we have. And so really we've learned, and this is very consistent with other centers across the country, what numbers they're seeing, plus or minus, in terms of the benefit of giving those antibodies from a survivor to someone who's struggling in the hospital. So I mentioned a few moments ago, we're seeing the rate of COVID-19 go up, the number of hospitalized patients go up, due to some really brilliant and wise planning by Garth England and Dr. Mike Waltz and the planning team there. We've been blessed with plenty of units of convalescent plasma. We have over 120 units of high titer plasma available as of this morning. But last week we had 12 units donated. We required 46, and so we have there are more going out, and that's just 1 week's worth. And so you're going to be seeing in the news here shortly that we really need to get survivors, and there are many of them out there. If they're within month 2 to month 4 from their experience with COVID-19, that's when we typically expect to get the high titer units. There's really a strong need for plasma donation, and so we're going to be seeing more of a push of that again. I do want to recognize some really key people with this project. First, and by far foremost, is the heroes, the donors. Most donors, when they donate plasma, that unit can be given to 3 or 4 people at times, and so there are and folks can donate multiple times. They have a gap where they need to rest, and then they can come back and donate again. We've had donors that have donated several times, and really, without a doubt, have saved lives. I mean, we can't say who, of course, but we know that this has reduced the mortality of COVID-19, and so these heroes, these folks that have not only survived COVID-19 but then decided to go donate, really have made a great difference. I do want to recognize some key members of the team. Dr. Dan Monkowski with infectious disease was the principal investigator for this study. Dr. Mike Waltz, I mentioned, and the entire Garth England team, they're incredible. On the research staff, Megan Collette and Sarah Twombly really played pivotal roles in making this such a success and getting so many patients on the trial. Now that it's been FDA approved, as I mentioned, we gave 46 units just last week. We're giving this in many patients. We actually are getting orders for plasma in patients before they even leave the ER. So the team is very much aware. On this slide, I want to recognize all the different physicians that were part of that, and there's quite a few. So I'm not going to read them because that would bore everyone to death, but really this was a UCHealth North-wide project. So other effective interventions that we did not participate in clinical trial, but I think are worth noting. So one is an antiviral called Remdestivir, and it works against SARS-2, so you'll see a lot of that. That is COVID-19, SARS-2 and COVID-19, that's the same thing. Dexamethasone, a steroid that we've had for a long time, an anti-inflammatory. But going back up to Remdestivir, if you look at this report, which was published, I believe, just a week ago, a 25% reduced risk of death at roughly 1 month. With dexamethasone, an 11% reduced risk of death. We're combining these therapies. It's not unusual at all for a sick patient in the hospital to receive plasma, Remdesivir, and dexamethasone. So we don't have data yet to say exactly what that cumulative benefit is. We'll get that with time, but individually we're seeing benefit with all of these different things. Something that's important in dexamethasone I think is worth saying though, it was definitely more pronounced the sicker the patient is, particularly in the ICU. There was actually no improvement in mild cases. So in outpatient situations, I know that's being prescribed at times, there's nothing wrong with that, but this particular study did not actually see improvement by adding dexamethasone in that setting. So some other interventions that we are part of, something that we're quite proud of, is our collaboration with CSU. And Dr. Elizabeth Ryan and Dr. Julie Dunn has started the Northern Colorado Coronavirus Biobank. And what they're looking for, and this is enrolling right now, is 300 patients that have COVID-19 or had it. And then they're volunteering to give blood, urine, saliva samples. What they're studying is the immune response, and then looking at that immune response with different modalities of testing, and then trying to learn more about both. We want to learn about the immune response. What does the immune system do in response to COVID-19, which is critical. And also we need to learn more about our testing. Is one test better than another? Are there limitations to one test, etc.? So not only are they studying the immune response, they're studying different modalities as well, which is a really neat project. So vaccine trials, and this is the last couple slides I have, and then we'll turn things over to questions and discussion. So there are 2 COVID-19 vaccine trials in Colorado. One is with our partners at UCHealth Denver Metro, that's sponsored by a company called Moderna. And then we have one in Northern Colorado at the ranch off of Crossroads in Loveland. That's the Oxford or AstraZeneca study, if people have heard of that. That actually reopened today. It was paused for a safety pause. The FDA and other regulatory bodies reviewed it and determined that it was safe to continue. And so we got permission to reopen Monday evening, and then we were able to reopen this morning. And I don't know how many patients we've had so far this morning, but I know volunteers are coming in and getting that vaccine trial. And we'll talk more about it in a second. So our particular trial, so I am not talking about the Moderna trial here. This is the AstraZeneca Oxford trial. This is a double-blinded, placebo-controlled trial, which means, and it's a 2-to-1 ratio. So of all the patients that come in, 2/3 of the patients will get vaccine and 1/3 will get placebo. I think that's very important to know. And we're looking at efficacy, and we actually have quite a bit of efficacy. How well does it work first? But then really the key now is we need more safety data. And that's really the big part of the phase that we're in now. And this is the website for those that may be interested in volunteering for the vaccine study. Like I said, it's placebo controlled, so there's a 2/3 chance of getting the vaccine and 1/3 of not. But we have many people that are signing up, and we're open Monday through Saturday and enrolling patients right now. So I want to look at the data that's been published already about this trial. So we already have the phase 1 data looking at the first 35 patients. And so this is a quote from this paper. So that initial study showed neutralizing antibody responses, what we believe to be something that would neutralize COVID-19, that's SARS-CoV-2. So after the first dose of vaccine, we saw those antibodies in 91% of patients, 32 out of 35. But after the second booster dose, in all 100%. And so, like many of the vaccines, not all, but almost all of the vaccines, this is a 2-dose series. So patients come in, get their first dose, and then over a month later come in and get their second dose. So in this study, so no concerning safety findings were found, and that led to the phase 3 trial, which we're participating in now. And so it was paused, as I mentioned, for a review of a neurologic side effect in a patient in the UK. And then the FDA decided to review all of the data around the world so far, so all 18,000 participants that the trial had so far. And it was determined Monday evening that it should reopen, and then we reopened it today. And so, like I said, not only do we want to continue to see, is this working, how efficacious it is, the key thing is the safety data, and so we're following these patients very closely over 2 years with a lot of upfront. So in the first 60 days, there's quite a bit of checkups to make sure everything's going well. I hope everyone enjoyed their break from lunch to talk about innovation in cancer care and COVID-19. I want to thank everyone for their time, and I think what we're going to do is actually questions that have been submitted are going to be read to us, and then I'll try to cover them the best I can. So thank you.
Dr. Schuster, thank you so very much for that extremely informative presentation covering many topics that are really top of mind for so many in our community today. So thank you, and thanks for all you do to care for cancer patients as well as to advance research here in Northern Colorado. We do have a number of questions, some that have been submitted through the chat and some that have been submitted prior. And the first one really relates to the intersection of cancer care and COVID-19. Can you describe, have patients in Northern Colorado delayed their treatments and screenings over the past few months? And what's your observation on the effects and overall outcome of those kinds of delays?
Yeah, so that's a fantastic question. So I appreciate whoever submitted that. I think this is something that has been quite upsetting to me, and I know to many of my partners. I think especially in the spring and summer, many patients delayed going to the doctor. They'd have symptoms, even chest pain, and would delay going. I've lost patients that I really don't think we should have because of delay of coming to let us know something was going on. We've seen more advanced leukemias than we ever had before. I think that what's key is that we are trying to make the cancer center as much of a safe haven as possible. If people are concerningly sick for COVID, we're not seeing them here. We're sending them to be evaluated elsewhere. I think other clinics, of course, are doing that too. I think even though, of course, we're fighting COVID-19, and that's a very important battle, we have to take care of everything else too. It's been quite sad to me, some of the stories we've had of situations where we've had delays and then, unfortunately, in some cases, haven't been able to recover. So, thank you for the question.
Absolutely. And for those who are currently engaged in cancer treatment, what steps should cancer patients take to continue to ensure their safety during the pandemic?
Yeah. So the question is, what should cancer patients do that might be unique during COVID-19? I think that there's not too much more we need to do. I think mask wearing is essential, social distancing, trying to minimize risk. If you need to go to the grocery store, trying to go once instead of 4 times, those sort of things that no one can be risk-free, but trying to minimize risk. I think that's key for all of us. I really don't have any additional recommendations for those going through cancer. I think it's more critical in immunosuppressed folks going through chemotherapy that if there's something that a friend can take care of or a family member, take advantage of that is key. But at the same time, I don't think it's appropriate to absolutely put yourself in a bubble where you're, completely isolated, almost to extreme quarantine. I think just trying to reduce risk as much as possible, in my opinion.
Thank you. Another question relates to the COVID vaccine trials. So is the focus on enrolling people at the highest risk in those trials? And a second part of the question is, what kind of diversity are you looking for with those who you're enrolling in the COVID trials?
Yeah, it's a great question. So asking really what participant are we looking for in the vaccine trial? Really, as long as they're an adult, there's really no limitation. However, really the focus is on those that are at highest risk for getting COVID-19. So our essential workers, our first responders, healthcare workers, food service workers, grocery stores, teachers, those that really the nature of their job requires them to be in closer contact than maybe we would like, but really it has to be that way. That really is the main focus. That doesn't mean we turn someone away because they're not in one of those groups, but that is indeed the main focus is that highest risk to get COVID.
Very good, thank you. And I know some of this information is available when folks fill out the survey to participate in a trial, but can you share generally how much of a commitment is enrolling in a vaccine trial? How many visits? How close do you need to be to the hospital? What's your availability need to be like?
A fantastic question. So if I could summarize it very simply, it's definitely more visits and more checkups early on in the first 60 days. Over a 2-year period, it's 10 checkups, but most of those are in the first 60 days. And then you get a new buddy, a clinical research coordinator that's kind of your contact person. If they'll be checking in with you by phone or however you choose. And if you were to get sick or have symptoms, of course, if they're serious, take care of them. But if you have questions or symptoms, you'll be in touch on what to do to get set up to be tested for COVID if there's concern for COVID and whatnot. So it is something that, there's quite a few visits. I mean, it'd be 10 visits over 2 years. 2 of those visits the majority of those visits would be out at the ranch in Loveland. We put it right off Highway 25, somewhat close to 34, so that really we hope people from around the region can come and not feel that they can't get there. Yeah, so hopefully that answers the question.
Thank you. The next question has to do more specifically with cancer research. Can you share some of the latest developments in research on non-Hodgkin's lymphoma?
Okay. Yeah, so non-Hodgkin's lymphoma, that can be a talk in and of itself, because there's over 65 different types of non-Hodgkin's lymphoma. And really, unlike 2 or 3 decades ago when we treated most people the same with non-Hodgkin's, really we're personalizing it now to the subtype. There's a lot of breakthroughs in immunotherapy, antibody drug conjugates, those things I talked about in the beginning sessions. Unfortunately, most of them still use some chemotherapy. A lot of times we've reduced the amount of chemotherapy by sometimes dramatic amounts. And so a lot of it is chemoimmunotherapy or targeted therapies. Yeah, so I mean, it's really been an exciting few years in non-Hodgkin's lymphoma. The way I treat patients now is completely different from when I was at Mayo years ago. I mean, there's almost no similarity. So in less than 10 years, having a complete shift in how we treat folks. So it's actually been a really exciting time.
That's wonderful. And I always appreciate that observation when one of our physicians can talk about the way that care has advanced during the span of their career. And it shows the value of research and knowledge and advancing our cancer care. So that's a great example.
I agree.
Back to COVID. What is the latest knowledge about how long COVID immunity lasts if you get it, or are you immune?
Okay, that's a fantastic question. I wish I could say I absolutely know that answer. I think that a lot of the research with our trials and with other trials, the reason we're following folks for 2 years is to learn more about that. I think some things we do know is that the antibody responses peak around week 4, which with IgM, so the first antibody that we should see in a lot of diseases peaks around 2 weeks. It seems to be with COVID-19, it's more like 4 weeks. And then the IgG, which is that memory immunoglobulin, which is key to your question, that typically comes up right around that same time, which is somewhat unique. It stays up and kind of at that high titer typically for about 2 months, plus or minus. We have donors that were exposed back in March that are still high titers, so it can be longer than that. But on average, kind of month 2 to month 4. then the antibody response does fade, like it does with all diseases. That's not a unique thing to COVID-19. What we really want to learn about is what is the ability a year later, 6 months later, a year later, 2 years later, is that antibody response sufficient enough? Does it ramp up enough to protect from COVID down the road? There are some diseases that, chickenpox, for example, varicella, where you get exposed to it as a child, and that antibody is great for decades. Other examples like influenza or flu that, year to year, people are at risk each year. We recommend a flu vaccine every year. So how COVID-19 is going to play out between those or like one of those, that's really hard to say. I think a lot of research is cooking or ongoing that's going to answer that question, but it's going to take time to see how those survivors do. Because Asia and Europe had earlier peaks than we did, I think a lot of that data is going to come from Asia and Europe first, but we're of course looking at that too. So maybe not what they wanted me to say, but that's the best answer I have.
Thank you. Good to shine some light and see how we might figure out what that answer actually is.
I guess I would say, so this is opinion now. I mean, I think that, the immune system is strong. Obviously, I'm a hematologist, so I'm pro-immune system. I would think that it would have some protection. What we really don't know is the duration of protection. That's my opinion, of course. And so I think it's going to last, but might we need to have booster vaccines down the road? That's something I absolutely don't know. Sorry to interrupt.
Yeah, no, thank you. That's good addendum. The next comment we have is one of our participants saying, I didn't know there are so many research projects in Northern Colorado. We're blessed to have Dr. Schuster in our community. And that's a wonderful commendation for you. I wonder if you could speak a bit to the role of community hospitals in research, because there's often an idea that research only happens in big city academic medical centers. But as we have shared here today, there is a lot happening here and it's really important.
Yeah. So I think community centers like ours, really that are a hybrid, our relationship with the university, and even before that, the commitment of the community to research is so key, because at community centers, we see really real world cases. When you're at a Mayo or an MD Anderson, et cetera, you're not seeing that patient up front. You're seeing them after perhaps they've been through 2, 3, 4 different lines of therapy or more. And so a lot of their focus in academia tends to be downstream, after things have failed and we're running low on options. Really, where we want to make an impact is we want to take that best swing first. We want to find out what's the best first line therapy. How do we cure this? How do we put it in such a deep remission that lasts for years and years? And community practices are really positioned best to do that, because we see those folks. Those are the people that are coming in first, and we're offering them that best treatment. And so having those clinical trials, so we can, and the vast majority of our studies, what they do is they take the standard of care, whatever I would normally think I'd want to do, and then try to add on to that or improve it in some ways. Sometimes adding on, sometimes switching to something we think is better. And so most of our trials are standard of care versus something that we believe is going to be better. Otherwise, we wouldn't be doing it. Yeah, so I think we're just in a perfect position, and so having that commitment in the community, that research is essential.
Very good, thank you. Looks like that comes to the end of our comments and questions for today. So again, thanks so much, Dr. Schuster. You covered a lot of ground and I think really reminded us of the invaluable work that's happening right here. So thank you so much. Thank you also to our outstanding production team from the UCHealth Northern Colorado Foundation. And thanks so much to those of you in our audience who are donors, community supporters. We very much appreciate your support and your participation today. As we've shared, contributions from our community help to make our cancer program among the very best in the world. So if you'd like to learn more about donating to support cancer care through the UCHealth Northern Colorado Foundation, we surely invite you to contact us. In addition to contributions to advance cancer research and some programs that we've talked about today, we also welcome contributions to our Cancer Patient Financial Assistance Fund. Now through the end of the year, Bank of Colorado, one of our generous corporate partners, will match gifts to this area, enabling you to double your impact to help cancer patients in our community. You can find more information on how to give in our meeting chat and in some of our follow-up communications. Again, we are so grateful to all of you for joining us today and for your support. I wish you a good afternoon and a season of good health. Thank you.